Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon. So this is the interesting part. We're going to now the time for the abstract presentations. And now we're going just to present two abstract for today. And tomorrow, inshallah, we're going to continue for the other four. So we're going to start with Dr. Hanan Hamzi. So for each presentation, it will be just 5 minutes. And then we're going to, if you have any questions, so you are welcome.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah, wassalatu wassalam ala Rasulillah. Thank you for giving me the chance to present our paper. The title of our paper is Early and Late Effects of Therapeutic Plasma Exchange in Patients with SLE and ANCA-associated vasculitis, and this is a single-center experience. The aim of our study was to describe the early and late effect of therapeutic plasma exchange in patients with SLE and ANCA-associated vasculitis who presented with acute kidney injury. We included all SLE and ANCA-associated vasculitis who were older than 14 years of age and who were completed their therapeutic plasma exchange therapy between January 2000 and June 2014 at King Faisal Specialist Hospital and Research Center in Riyadh. All patient files were reviewed in respect to demographic features, age of onset, disease duration, clinical and laboratory variables, treatment, as well as indication for therapeutic plasma exchange. To evaluate the treatment outcome, we considered the assessment at the time of enrollment, 12 and 24 months intervals, using SLEDAI and Birmingham Vasculitis Score, activity score, and for renal outcome, we used serum creatinine level, GFR, active urine sediment, and protein creatinine ratio. The early and late therapeutic response were assessed at the 12 and 24 months interval after therapeutic plasma exchange, respectively. We used the mean plus minus standard deviation for continuous variables, while a number percentage was used for categorical variables, and non-parametric testing, we use it to assess the association between variables, and we considered p-value of less than 0.05 as statistically significant. We have total of 68 patients, 58 patients with SLE and 10 patients with ANCA-associated vasculitis. All patients, they have acute kidney injury upon presentation, and all patients, they have active disease upon enrollment. 48% of patients, they have pulmonary hemorrhage at the time of therapeutic plasma exchange in SLE group, while 50% of patients, they have it in ANCA-associated vasculitis. Cerebritis were found in 41% of patients with SLE, while crescent formation was there in 9% of patients with SLE and 50% of patients with ANCA-associated vasculitis. About 2/3 of patients in both SLE and ANCA-associated vasculitis, they required hemodialysis at the time of therapeutic plasma exchange, and cyclophosphamide was given in 66% of patients with SLE and 70% of patients with ANCA-associated vasculitis. The most frequent histopathological class was proliferative glomerulonephritis, followed by mixed classes, and most of the cases in ANCA group were Bose-Ommion glomerulonephritis. At the first 12 months interval, around 18 patients, they achieved complete remission, and 14 patients in both groups, they achieved partial remission. 22 patients, they did not show any response, and 4 patients lost follow-up. The 22 patients who were non-responder, they entered the second assessment interval after 24 months without any therapeutic improvement. Unfortunately, 10 patients died in the first 3 months after therapeutic plasma exchange. The most common cause of death was sepsis with fungal infections and refractory pulmonary hemorrhage. 17 patients developed end-stage renal disease, and 7 of them underwent renal transplant. There was no significant difference between patients' response to therapeutic plasma exchange at the first, i.e. after 12 months, and the second assessment intervals, which is after 24 months. There was no statistical significance association with the response to therapeutic plasma exchange and the baseline serum creatinine level or the type of immunosuppressive therapy that have been given. And to the best of our knowledge, this study will be the first available published data from the Middle East about the use of therapeutic plasma exchange in SLE and ANCA-associated vasculitis, and highlighting the early and late renal outcome in these type of patients. And we believe that therapeutic plasma exchange might be an alternative rescue treatment in lupus nephritis with acute kidney injury. And our paper has been accepted for publication in Saudi Journal of Kidney Disease and Transplantation. Thank you.
Thank you. So we do have time for one question. Okay. Okay, so we're going to proceed for the next presenter, Dr. Fahed Al Anizi. She's from the Amira Noura University.
Assalamu alaikum. Thank you for giving me this chance to present our abstract. Our study was about the value of screening of celiac disease in systemic lupus erythematosus. We studied the celiac disease autoantibodies in pediatric and adult lupus patients. Which one? This one. Okay, sorry. We know that patients with autoimmune disorder have a higher probability of being affected by another autoimmune disease like SLE, rheumatoid arthritis, diabetes, or thyroid disease. And we know that many autoimmune diseases have been described as occurring concomitantly with celiac disease. And we know there are few studies and several case reports indicating the association between SLE and celiac disease. But the real prevalence between celiac disease autoantibody and SLE is not well documented. So our objective in this study was to assess the frequency of celiac disease in adult and pediatric systemic lupus erythematosus, and to investigate the clinical impact of serological markers of the celiac disease in SLE disease activity. And this is the first study to highlight this. Of course, this is a cross-sectional study, included SLE patient who had a regular follow-up, rheumatology clinic at King Faisal Specialty Hospital Research Center in Riyadh. All patients met the criteria for lupus. Patient evaluated for clinical and lab variable and SLEDAI. All patients tested for the most specific celiac antibody, the anti-tissue transglutaminase antibodies, and anti-endomysial antibody and the anti-gliadin antibody using the standard ELISA and immunofluorescent method. And of course, we measured the IgA level. Result compared with those from RA and GIA patients, because at that time we have difficulty to have a healthy controlled population. Patient with positive celiac markers underwent a duodenal biopsy. So we have a total of 250 unselected patients enrolled in our study, 81 adult SLE, the mean age was 34, and 34 patients from the pediatric SLE with a mean age of 10. The mean SLEDAI was around 9. And the comparison group, we have 62 RA patient, mean age of 49. GIA was 73 with mean age of 10. All patients were asymptomatic for celiac disease except one GIA patient having chronic diarrhea. For the celiac disease serological marker, we found from the 81 adult SLE patient, only 9 have positive celiac disease, and only 2 have positive TTG antibody, which is the most specific antibody for the celiac disease. And from the 34 patient childhood SLE, we got 6 patients, and again, only 2 patients have positive for the TTG, and the rest mix between endomysial and anti-gliadin antibody. For the 62 patients from RA, we have 6 patients positive for celiac disease markers, only 1 positive for TTG, and the GIA patient, we have from 73, 8 positive. The GIAs have the higher percentage have positive TTG. So patients with positive celiac disease markers were comparable to those with negative marker. 15 out of 17 positive TTG or endomysial positive patient. Unfortunately, 2 patients declined to proceed for endoscopic biopsy. The rest, we did for them biopsy to confirm the presence of celiac disease. We found that none of SLE patients having histological feature of SLE, only 1 RA patient and 1 GIA patient having the histological changes for celiac disease. And again, celiac disease marker positivity was not correlated with SLE, autoantibodies, or even the SLEDAI. So in conclusion, our study confirmed the increased frequency of positive serological celiac disease marker in SLE patient, but the accuracy of celiac disease markers in asymptomatic SLE patient is doubtful, and the presence of serological celiac disease marker has no impact on the clinical presentation or comorbidity and did not influence the SLE disease activity. The limitation in our study was it was a single center experience, 1 visit assessment for the patient, and of course the lack of healthy control. Thank you.
Okay, thank you. So any question for Dr. Haida? Okay, thank you. There's just one thing we didn't finish yet from the abstract presentation. Tomorrow, inshallah, we do have 4 presentation more. Thank you.